Alrighty, hello everyone. My name is Grace Dennis, and I'm happy to welcome you to the 6th annual Cannabis in Practice webinar series hosted by the Washtenaw County Health Department and the Livingston County Health Department in partnership with the Washtenaw County Medical Society. This webinar series is aimed at addressing questions our local, regional healthcare providers have about cannabis use and their patients. Our speakers come from a wide range of backgrounds and are experts in their respective fields. Funding for this series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. This live webinar has been approved for one social work continuing education clock hour, one specific McBAP credit hour, and one credit hour of CME. If you are requesting any of these continuing education credits, please be sure to stay on until the end of the webinar to fill out our post-webinar evaluation survey. Please be sure to provide your name and email address to ensure that you receive certification for your attendance. This webinar is being recorded. The webinar recording and presentation slides will be available on our website at washtenaw.org/marijuana in the coming weeks. Before we get started, we ask that all questions for our speaker be submitted through the Q&A function, which can be found at the bottom of your screen. We will have time at the end of the webinar for the speaker to answer questions. I am pleased to introduce today's speaker, Dr. Roneet Lev. Dr. Lev is board certified in emergency and addiction medicine and practices on the front lines. She was the first chief medical officer of the White House Office of National Drug Control Policy from 2018 to 2020. After being chief of the emergency department at Scripps Mercy Hospital in San Diego, in her role as Chief Medical Officer for the Center of Community Research, she chairs the San Diego Community Response to Drug Overdose Task Force, bringing together the 3 Ps: public health, public safety, and prevention leaders. In 2012, she established and chaired the San Diego Prescription Drug Abuse Medical Task Force, and the first of its kind in California. Lev's medical publications, known as the Death Diaries, studied the details of prescription patterns of people who died from accidental medication overdoses. Dr. Lev is the current executive director of the Independent Emergency Physicians Consortium, served as the president of California chapter of the American College of Emergency Physicians in 2000, and is the founder and vice president of ISIC, the International Academy on the Science and Impact of Cannabis. Lev is an energetic leader with a passion to assist communities in preventing and treating addiction. Lev hosts the podcast High Truths on Drugs and Addiction. If I could advance to the next slide for our CME disclosure. None of the planners or speakers for this educational event have any relevant financial relationships with ineligible companies to disclose. I am now happy to pass it on to Dr. Lev. Thank you all so much for being here.
Thank you so much for that kind introduction, and happy to join you guys all the way from San Diego. So presentation, it's just pot, what's the problem? And I'm going to share that with you from the eyes of an emergency physician. Data is interesting and always drives the conversation. So in San Diego, we recorded a few years ago 37 cases a day of cannabis-associated illnesses that come to the emergency department. And as you could see, that's been rising ever since legalization. So I could go through a lot of statistics with you, but that tends to be boring. So I thought what I would do instead is take you on a shadowing trip with me in the emergency department. So we're going to go with me on a shift in the emergency department. Hang on to your straps. It's going to be a hectic shift. Here I am coming through the ambulance bay instead of the main entrance, sliding in through security and coming in to log onto my computer. I've been a germaphobe way before COVID. I learned the hard way. And logging into my computer, and this is what I see as I enter my screen. So now we're going to show you through this shift. I'm going to go through 10 patients and 10 scenarios about why pot is a problem. But here's my screen as I log in. This is a morning shift. Luckily, after, I don't know, 30 years of night shifts, I finally aged out of night shifts. But so I'm here now on the morning shift starting at 6 o'clock, getting handover from the other physician who did the night shift. Sorry, I'm showing you my screen. And kind of close up, you could see what I call the sea of red. Red is people who've been waiting in our emergency department for many hours. And you can see some of these hours are really sad, 189 hours, 8 days. People are living in our emergency department. This is not just for San Diego. This is a problem throughout the country. And they're all there for psychiatric holds. We have a real problem, psychiatric holds throughout our country. So we have a system now that anybody who's been there overnight, we just don't forget about them. My first job in the morning is to go check on these patients. So come with me as we're going to go check on. This little room here, it used to be our chest pain center. Cardiologist didn't like it, but we took over and made it our little behavioral health ward just for the emergency department. It's 4 locked beds. It's not enough. It's always overflowing, but this is where I start my shift and kind of rounding on the patients who've been there. So here's patient 1. A 37-year-old man who's been waiting for a behavioral health unit bed for 7 days. He's been there for a long time. The sad part is he was just discharged from a similar behavioral health unit in Los Angeles after he cleared up, was medicated, doing well, and felt to be safe to be discharged. He was given a bus pass to go visit his mom in San Diego. And while on the bus, he lit up, used marijuana, and didn't even make it off the bus before going into florid psychosis, made it from the bus to our emergency department where he was still sitting, getting treated and waiting for a bed. By the way, all these cases I'm showing you today are real, but they're HIPAA protected, so you won't be able to figure out who they really are. So problem number 1 is addiction. This guy didn't make it very far before having the need to use marijuana again. Marijuana, like many drugs, are addicting. And here's a little bit about the physiology of addiction. When you use drugs, you have an increase in dopamine. That feels good. That's kind of why people use it. You use it. Now, if you have more dopamine, then your body feels like, well, I'm getting dopamine from the outside. I don't need to make my own if that continues to be a surge. So if the body is used to getting dopamine again and again and again from an outside source, then the body itself will say, hey, I don't need to make my own dopamine. I will downregulate my receptors. And then it creates a vicious circle where you need more and more dopamine. Dopamine is a neurotransmitter that you need to live. Without dopamine, it's like having no oxygen, no water. You need that. And if you don't get it, you feel like you're dying. Now, how much surge in dopamine? How much do you need? Like you and I talking through Zoom today, baseline of 15 to 40 units. The best day of your life, you're getting married, winning the lottery, as 100 units. But you could see that drugs, marijuana, heroin, methamphetamine, way exceed anything naturally that happens in the body as far as dopamine surge. So cannabis use disorder, that's another way of saying addiction, is present just like alcohol use disorder, opioid use disorder, and the percentage of people who are addicted, it varies depending on potency, use, and age of onset. So the data shows us 9% of adults have a cannabis use disorder. For people who start using drugs or marijuana at younger than 25, the age of the growing brain, it's 17%. And for people who use every single day, high potency from a young age, it could be up to 50%. And when there is addiction, there is withdrawal. And if I talk to my patients who clearly have a cannabis use disorder because they're there in the emergency department with cannabis-associated poisonings, if I ask them, can you quit? And they all say, oh, yeah, I'm not addicted. They all believe that they can quit. Until I explain to them what cannabis withdrawal symptoms are. It's not like alcohol withdrawal where you have shakes or opiate withdrawal where you literally get sick. It's more like caffeine or nicotine withdrawal where you can't sleep. You have a headache. You're very anxious. So a lot of people say, I need to use cannabis for my anxiety. Is it, or are you really just covering up the addiction and the withdrawal symptoms? And it's important to just note that addiction is a chronic, relapsing, yet treatable disease of the brain. This happens to be pictures of a PET scan for methamphetamine, but it's similar for many drugs, where you could see here less dopamine receptors in the brain, and it's recoverable. You can treat this, it could take time, but you can get that back if you stop using drugs. All right, so I'm back at my computer, saw all my mental health patients that I need to round on. I'm trying to dictate, and this is what I hear. I have my face to the computer, And I call this an audible diagnosis. I hear this sound, and there's only one thing it's going to be. And that is the next patient, 28-year-old, brought in by ambulance, retching, screaming, putting her finger in the throat to try to throw up. Feet are in the air, horrible. She is absolutely miserable. And this is a symptom of cannabis hyperemesis syndrome. Nothing sounds like this. It's horrible. People are miserable. They want pain medications. That's actually what got me into speaking about and learning more about marijuana was from the opioid epidemic, because we were trying to curb the medical community from prescribing opioids. At the same time, we had these patients addicted to marijuana who were begging for opioids. And I said, you know what, wait a second, we can't create a new addiction for these patients. We created a protocol on how to treat cannabis hyperemesis syndrome without opioids. And at a news conference where we showed this, I talked about that patients are scromiting, screaming and vomiting. That word, scromiting, became viral. Now you could see it in, and I'll Google it and search it and you'll find it. It's all in the lexicon of people who use marijuana. And it's probably like better than any publication I ever did was that creating that word, scromiting or publicizing it. All right. And that brings us to problem number 2, which is potency. Marijuana today is not what it was back when marijuana was legalized. The drug has evolved even since then for California. When people voted to legalize marijuana, they did not expect this type of potency and conglomerate of drugs. And here's an example, just to look at potency. FDA approved Marinol. Marinol is pure THC that I can write a prescription for select patients who have HIV wasting or chemotherapy associated nausea. The maximum approved by the FDA is 20 milligrams. That's not the starting dose, that's the maximum dose. And interestingly enough, and I'll show you, the FDA predicted all the poisoning effects that I see in the emergency department. A 1990s joint was higher than what the FDA approved at 50 milligrams. Today's joint is 4 times that at 200 milligrams. Now, edibles, 100 milligrams per package. Concentrates can be up to 90% THC. And that's a hard drug. That's not the old, get munchies and I want to relax marijuana. And now what we're seeing in the emergency department in traffic fatalities is, again, this agitation, hyperactivity, not the mellowing effect. When you look at research that says marijuana is good for this or that, they were not testing or researching these high potency products. It's actually even very difficult to find low potency THC now in dispensaries. All right, what do we got next? Okay, going down the hallway to our next patient. All right, there we go. Next patient is a 31-year-old brought in by her boyfriend for acting strange. She's just talking kind of like really withdrawn, closing her eyes. I could recognize this behavior as somebody who has voices in their head that are talking to them. She's hearing voices. You can't see that unless you ask her. But her boyfriend said she's not acting right. Bring her in. And as I get undressed and I look and I see a bunch of lacerations on her head. The picture in front of you is of Bryn Spacer. Bryn was not my patient, but she is a woman in California, Thousands Oaks, California, went on a date with her boyfriend, had a hit of a bong of her boyfriend, a second one, and had a horrible psychotic reaction, cannabis-induced psychosis, in which she stabbed her boyfriend 108 times, killed him, stabbed her dog, stabbed herself. She would probably be dead if police didn't arrive at the scene, and had to hit her 8 times with a baton to get the knife out of her. And she recalls this event. She believed that she was dead, and she had voices in her head that told her, keep stabbing, keep stabbing. The more that she was stabbing, the more she could bring herself back to life. And that was her psychosis. She was taken to court for involuntary manslaughter and received community service. She, educated young woman, talks about her experience, and you could debate on whether she got, just punishment or not. But what it does show us that this is cannabis-induced psychosis. And if you read a lot of articles that say, oh, this is a rare event, it is not a rare event. We see this in the emergency department, maybe not as dramatically as Bryn's case, but it's there. And that brings us to problem number 3, which is mental health. Here's a recent chart from a study done on 900 different patients over a period of time in Canada that showed, and you could see these 2 different graphs, one people who use cannabis, one who don't use cannabis, and it shows that for the ages of 12 to 19, if people use cannabis in that age group, your risk of psychosis is 11-fold. Other studies from Europe showed a overall 5-fold increase of risk of psychosis. So again, this is significant. Now, not everybody who uses marijuana is going to have psychosis, which will then develop to bipolar or schizophrenia. Just like not everybody who smokes cigarettes is going to get cancer or emphysema, but it's a risk factor. It's an undisputed risk factor that we just have to acknowledge. And the risk is higher when you're in that tender age of the brain developing. Cannabis-associated suicide is real. I challenge you to look at the data in Michigan. Look at people who died by suicide under the age of 25, and you'll probably have a similar graph. I did this, I copied Colorado. Colorado has all this data, and it showed, again, the #1 drug by far, more than alcohol, associated with death by suicide under the age of 25 is THC. The picture here is of Johnny Stack. He also developed cannabis-induced psychosis, thought he could fly, thought the mob was after him, jumped off a building to his death. And his mom, Laura Stacks, now really helps a lot of parents whose children are going through the same type of problem. All right, what's going on back in the emergency department? Let's see what we got. All right. Oh, we have a cute little baby. And that is a cute little baby because that's my granddaughter. The baby I saw behind the curtain was not so cute. She was laying with her eyes rolling and rattling in her head, semi-conscious with encephalopathy. She got into her mom's gummy. This is the exact brand that was used, got into her purse, took the gummy, and became encephalopathic. Marijuana is very fat soluble. It means it likes to attach to fatty parts of your body. One of the fattiest parts of your body is your brain, and there's no antidote. You just have to wait. And she was admitted to the ICU over several days until her body naturally got rid of the marijuana. I gave this talk in Missouri, and one of the ER doctors in the audience says, yeah, I just intubated, a 5-year-old who had the same kind of thing. This is not rare. So problem number 4 is pediatric poisoning. And we are seeing that across the country. The #1 cause of poisoning in children under 5, these are babies, they do not have a cannabis use disorder. They are getting into their parents' stash. We actually did studies that showed where kids getting this marijuana. #1 is mom, #2 is dad, and then other family members or people around them. The mean age is 2 years old. And we've had a 13-fold increase in pediatric poisonings from marijuana, over the past few years. And these kids are not giggling. They are requiring ICU care. Some of them need to be on a ventilator. So at least if you're going to use marijuana, buy marijuana, lock it up like you would lock up your guns. This is no joke for these kids. All right, what's next?
Co-trauma.
I work in a level 1 trauma center. When we hear those words, trauma, there are several staff that come to our trauma center, the trauma doctor, the emergency doctor like me, radiology, laboratory, and a whole host of people ready to treat whatever comes in. And in this case, it was a motor vehicle collision. The person who was hit was killed. He died. And I treated the other driver, who was a young boy, 25 years old, with alcohol and marijuana. Those two are additives. People kind of know that, you shouldn't drive drunk, but they don't know that you add a little marijuana to that, and maybe the legal limit is 80, which is the arbitrary cutoff, but your impairment goes down. So that's more like driving on a higher level. Those drugs are additive in nature. And that young man I treated, he'll be okay, but for the rest of his life, it'll never be the same. He'll have to live with the fact that he cost somebody else's life. So that's number 5, drug driving. Again, alcohol and marijuana are additive. If we look at traffic fatalities of people who are killed, if there is marijuana on board, there's a 2-fold likely increased risk of death. We've actually done simulations tests, and there's a website called Trez. You could access it. And they have educational courses with students, with young people teaching of prevention in drug driving. And we've actually taken people who use marijuana, smoke marijuana, put them in a car simulator and see what their effect is. And the thing is, people don't have the perception they're impaired. They feel like they're okay. Yeah, I could drive. But if you measure their impairment, they are impaired. So from this study, the recommendation is to wait at least 4.5 hours after smoking before getting behind the wheel, 8 hours or more for edibles, and you're not sober unless there's no alcohol and no drugs, and really any type of drugs, not just marijuana, even prescription drugs. And the other messaging really from we learned from this education is friends do whatever it takes to prevent not just drunk driving, taking away the keys, but also drug driving. All right, I just came out of the trauma, and Andrew here gives me an EKG. We have a new, a system to look at every single EKG as soon as it's done. He shows me this, and this is what the EKG shows. Atrial fibrillation, 42-year-old with a rapid heart rate of 160. This is a cardiac emergency, but something that we know how to treat. I give it a electrical shock or medication. We know how to treat that. That's the easy part. The part to think about is like, okay, well, what causes this atrial fibrillation in the first place? And sometimes the reason behind the diagnosis is not so difficult. And it was right on his shoes. And a lot of people don't realize that marijuana is associated with a lot of cardiac events, including atrial fibrillation. And that brings us to problem number 6, physical health. The Heart Association clearly has a white paper that says the data on heart risk with marijuana. Sadly, the public is not aware of this. When I tell my patients this, they're like, oh, nobody ever told me this. But the data is there. The risk of stroke, 3.3-fold, heart attack, higher incident, cardiac death rates for marijuana users, higher blood pressure, arrhythmias. If you are a heart patient, you really should not be using marijuana, just like you shouldn't be smoking cigarettes. What about the lung? Amazingly, some people say, oh, I use marijuana much healthier than those tobaccos. Smoking anything is not healthy. And marijuana and tobacco have the same toxins, same carcinogens. As a matter of fact, they've done studies. They looked at CAT scans of people who smoke cigarettes versus CAT scans of people who smoke marijuana. And the marijuana smokers' CAT scans look worse, which makes sense because you hold it in, you leave the smoke in your lung longer. It sticks around. And they've done studies for secondhand smoke and compared marijuana, a Marlboro cigarette, a joint, a blunt. And when they compared secondhand smoke, a blunt of marijuana has 3.5 times as much secondhand carcinogens than a Marlboro cigarette. They've also have done studies with vaping, and they looked at for every one person who may quit smoking by using an electrical cigarette or vape pen, we've now created 80 new adolescents who never would have smoked anything if it weren't for those vapes. And they translated that to over 3,000 lives saved. We've now cost 1.5 million lives lost. So you could do the public health analysis on vaping. Cancer, testicular cancer, 2-fold higher increase with marijuana users. The American Cancer Association definitely cautions about relying on marijuana to treat symptoms. So a lot of things that we see is delay in diagnosis of various cancers or various illnesses because people think, oh, well, let me use this, and it masks symptoms and delays a cancer diagnosis. And also, we know from genetic status that THC, what weed whacks your DNA. It changes the DNA. It's a teratogen. And a little picture in the green is sperm, happy little sperm swimming around, and then sperm on weed. All right, what's next? So here I am in the room. Sometimes we have critical patients come in by ambulance. We're notified by the EMS that they're coming, and we sit there, a whole group of us, waiting for a critical patient. So here comes a critical patient, 68-year-old, vomiting blood. He's been in the hospital 2 times. This is his 3rd time. He's on Plavix, which is a blood thinner that he needs for his heart stents. He's required transfusion before, and we're going to save him. We're going to give him blood again. We're going to transfuse him, get his blood pressure up. The medicine part sometimes is easier than the diagnosis. And a lot of people don't realize that there's a lot of drug interactions. If you're taking Plavix or any other blood thinners, you probably shouldn't use marijuana because it thins your blood more. And so that brings us to problem number 7, which is drug interactions. And if you're going to get one thing out of this lecture, this is the one that I want you to get. I want you to know drugs.com, because I know that you all have friends, relatives, people that you know who use marijuana. It's ubiquitous in the United States. And I want them to make informed decisions. So if you go to drugs.com, and if you have people that you know that are taking medications, a blood pressure medicine, anxiety medicine, a sleeping pill, seizure medicines, go to drugs.com, go to the drug interaction checker, put in cannabis if you're using THC, cannabidiol if you're using CBD, then put in whatever your lisinopril, whatever blood pressure, whatever medicine that you're seeing, and read for yourself and make an informed decision if you should continue using the marijuana or not. If you go to drugs.com, you'll see 377 different medications that interact with cannabis, and 529 different medications that interact with CBD. And these numbers actually could be checking, but that is what you want to make an informed decision. I have my patients do this for themselves. If they are using marijuana, I'll say, take out your phone, make a decision for yourself. And I teach them how to do that. And patients are like, wow, I never know. And they're very thankful. All right, for anesthesia, going to surgery. I recently had surgery. I was very proud of the anesthesia department that, said, listen, don't use any marijuana or any type of herbals or anything before your surgery. There is a recommendation to universally screen anybody for marijuana use before surgery. And why? Because, the anesthetics don't work as well if you're using marijuana. All right.
Dr. Lev to Sweet Delta. Dr. Lev to Sweet Delta.
All right. Barely finished one patient and got to run to the next. When the nurses call, I drop everything and go to what they're asking for. They don't call unless it's a real emergency. I've learned to kind of hear that. And here it is, an active seizure. This is a gentleman who's having an active seizure. We can treat the seizure. We can make it stop, even talk to him afterwards. And he'll say, yeah, I have a seizure disorder and I use marijuana for my seizure. Again, problem number 8, misleading health claims. How many people here probably have heard that, hey, marijuana helps seizures? That's only like a fraction of the truth. And I can explain the marijuana part. Marijuana helps seizures in babies with Dravet syndrome, very rare seizures. And it's not marijuana, it's CBD that helps that. But if you look at the FDA label of marijuana, it actually decreases your seizure threshold, and using marijuana increases your likelihood of having seizures. So people talk about medical marijuana. I put it in quotations. The reason I put it in quotations is to make it clear that a medical plant and a recreational plant is the same plant. A medical dispensary and a recreational dispensary sell the same thing. There's no difference in plant quantity. Medical users, in a survey of California that wanted medical use as compassionate care for people who have cancer, HIV, that's 3% of people who have medical use. The average age of medical users is 32. It doesn't take much to get a medical card. As a matter of fact, there's no standards of prescribing that follow what I have to go through to prescribe you a Tylenol or amoxicillin. There are strict standards on me for having a medical license for prescribing or recommending anything. These standards are not followed when it comes to medical marijuana. If you really want to know, is marijuana healthy? What is the research? We don't have enough research. How many of us has? We need more research. The research was done years ago by the FDA when they approved THC for medicinal use for those things. And if you just go to your favorite search engine, put in Marinol FDA label, then you could read and see this for yourself. And I'm really amazed by the FDA that they were able to predict all the things that I see now in the emergency department: neuropsychiatric adverse events, hemodynamic instability, seizures, paradoxical vomiting, fetal harm, geriatric use. I mean, they predicted this years ago, and it's right there on the FDA label. And we kind of talked about seizures, that THC actually decreases the seizure threshold. The American Epilepsy Society says, don't use marijuana to treat your seizures. They clearly state that. CBD, that's available by prescription, is what is used for pediatric. These babies, again, they were not smoking dope. They were getting CBD oil. There has to be caution also about buying these things over the internet, because it's not, what you're buying is not always what it says on the label. There are a lot of people who use marijuana for pain, sleep, nausea. Again, the studies with that were done do not promote the use, especially not compared to things that are available by prescription without you know what they are. Pain is a big one, and we actually have seen that people who use marijuana, it doesn't reduce their opioid use. In fact, they use more. I see patients who are in pain after surgery. If you're using marijuana before your surgery, you're going to have more pain, not less. And that's what the studies have shown. All right, what's next behind the curtain? There's a lot more that we talk about pain, but this is a whirlwind tour of the ER. Okay, behind the curtain, 76-year-old gentleman is bought in, confused, not acting right. They were on a family reunion, and grandpa told his grandson, you know, I take all these medications and I can't sleep and life is hard. And the grandson thought, oh, I felt sorry for grandpa. I wanted to help him, and suggested, hey, why don't you try one of these brownies? And what parents not going to listen to their grandchildren? We love our grandchildren. And took a brownie, and it worked. He slept the best sleep he ever had. The problem is he didn't wake up. He developed encephalopathy, kind of like that baby you had, that gummy bear. And we've seen in California, 1,804% increase in ED visits, emergency department visits, because of marijuana in age over 65. Really, older people are taking other medications. Their metabolism is slower. And this is exactly what happened to this man. His liver wasn't working. You need your liver to metabolize marijuana. So somebody else who may be eating a brownie with a good young liver can, eat it, have whatever high, and get rid of it. But grandpa couldn't, and he was admitted to the hospital for several days. There's no antidote until it came out. Problem number 9 is product integrity. And JAMA, the Journal of Medical Association, has done studies. They've done it with marijuana. They've done it with CBD. And they looked at the label and tested the products and showed that there's very little accuracy in the product labeling. It could be over-labeled as far as potency, or under-labeled. And also there are a lot of contaminants. And that's why the CDC has an alert for organ transplant patients, for anybody who's immunocompromised, not to use, especially the smoked products, because of infection. In a study of 20 legal dispensaries in California, legal medical dispensaries, they bought marijuana flower product, and 100% of them, all of them, were found to have contaminants such as Aspergillus, E. coli, Klebsiella, various types of infections. These are known, and that's why the CDC has their warning. So I'll have cancer patients saying, well, isn't it better for me just to smoke some little marijuana for my pain rather than take those terrible opiate medications? And I would say, no. That's what the pain medications are meant for. We know what dosage those are not contaminated. And if you're immunocompromised as a cancer patient, you don't want to increase that risk of infection. All right. Let's see what's next behind the patient. This is our last patient, 21-year-old, who presents with a headache after being assaulted. She is there with a 2-month-old baby. And again, a lot of times, I say this is the difference between a good emergency department physician, a great one, is like treating the headache after assault. That's easy. But wait, we got to look at the whole picture. Here's a young girl with a 2-month-old, and she's telling me that she's been using weed since she's 16 years old. She's in a, assaultive type of relationship here. We need to call social worker, but also there's a problem here with the growing brain. Her growing brain and the baby's growing brain. And so that talks about the growing brain. And I think you all know this. I talk to kids and they all know, and I'll ask them, how old are you when your brain is done growing? And they all know 25. They got that age, mid 20s. How is the brain growing? The frontal lobe is the last part of your brain to get myelin and for synaptic pruning to end. And that is a decision-making part of your brain. And because of that, the chances of addiction are much higher for people whose brain is not developed. So people who use marijuana under the age of 25 are up to 7 times more likely to develop a substance use disorder, not just for marijuana, but any drug, than somebody my age. All right. And that's why the Surgeon General has issued an advisory on marijuana. We have one for tobacco. There is one for marijuana and the growing brain, saying, you know, again, if you're pregnant, you should not be smoking tobacco or marijuana. That says clearly the brain is growing. You have to protect the brain of the fetus and the brain of the young person. And here's a journal, Surgeon General saying this ain't your mother's marijuana. Again, talking about the potency. It's important to talk about social norms. And that's important if you're talking to young people, if any of you are talking to young people, because I have a whole presentation about the harms of marijuana and how every single day, every single shift, I take care of somebody with marijuana poisoning, and I showed you examples of what that looks like. But if I'm talking to a young person, I do this with every young person I see in the emergency department, ask them to use, and then I'll say, good job for not using. And most people are actually not using. So it's important to promote the social norms. So here in this little survey, what percentage of people 18 to 20 years old, that highest likely use of marijuana, did not use marijuana in the past 3 days? What percentage? You guys can kind of like guess to yourself. But most people do not use marijuana on a daily basis. That's the social norm. It seems like that everybody's using it, it's everywhere around us. But when you're talking to young people who are very influential, they want to be like everybody else. You want to be like your peers. You want to promote that social norm that most people are not using. Because otherwise, if you don't say that, it seems like everybody's using it. And the person who's not using it, they're quiet in the corner, not saying anything. But they're the majority. So you're actually giving a voice to the people in the majority to say, yeah, I'm not using. And more kids, actually, we've seen this in surveys, are making the choice not to use anything addicting. They're making the choice not to use alcohol, tobacco, marijuana, anything addicting until age 25. They're making that commitment. We're seeing more kids making that healthy choice. All right, 10 patients, done with my shift, 10 hours. I love my job, but at the end of that, especially if seeing 30 patients, I'm ready to close my computer and end my shift. And here's some resources for you. I told you that the one thing that you're going to remember out of this lecture is drugs.com, for your own, self and people that you love and people around you. That's just if you're taking medications. If there's a second one, I'd say go to ISAC, the International Academy in Science and Impact of Cannabis. They have a medical library. Everything I said on this lecture is sourced. And I know you're not going to remember that. So what are you going to do when you're at a dinner conversation and you're going to say, hey, the risk of psychosis is 11-fold or 5-fold. It's really high. And you're going to go to your phone and you're going to go to isaac1.org, go to the medical library, look under psychosis, and there it is, the talking point and the source of where to find that talking point. So I really encourage you to use the Isaac library. And the other great source is the FDA label. The FDA, we could, whatever you think about FDA after the COVID pandemic and stuff, but they are our gold standard. They're the gold standard for not just our country, but for the world. And without the FDA, my profession is mute. So really count on them and their integrity for medications. They've done this research. Go to FDA label for Marinol or FDA label for CBD, cannabidiol, and look at the risks. And they clearly are stated for CBD. There's clear warnings on liver toxicity, suicidal ideations, for example. And be very cautious in buying things from Amazon. You could buy anything now, on the internet. But what it says, no matter what the fancy label is, you can't trust it unless it has an FDA label, or Another trick is if it has a USP label. So for example, I use vitamin D. If I'm going to buy vitamin D, which is considered an herbal, it's not, I buy it over the counter. I buy one with a USP label, and that way I know I could trust that it really has the number of international units that it says to have on the bottom, on no other, contaminants. All right, so I finished a little bit ahead of time, and so that gives us plenty of time for questions. I hope you have a lot of questions. If you'd like to hear more from me, I look at all the different aspects of drugs and additions, not just marijuana, but all sorts of different drugs. And you can follow my podcast, High Truths on Drugs and Addiction. And I know I talked fast. You got a whirlwind tour of the emergency department with a lot of cases and a lot of statistics, and you'll get the PowerPoint. So if you want to sit with the data a little more, you'll be able to do that. And I will stop sharing.
Thank you so much. That was a wonderful presentation, Dr. Lev. So many interesting facts, and I loved your new edition of the day in the life with you in the emergency room. That was great. So we are now going to open it up for questions for Dr. Lev. We do ask that all questions be submitted through the Q&A function, which can be found at the bottom of your screen. While you submit your questions, I do have a few reminders to share. First, this webinar recording and the presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. Also, this live webinar has been approved for 1 social work continuing education clock hour, 1 specific McBAP credit hour, and 1 credit hour of CME. If you're requesting any of these continuing education credits, please fill out our evaluation form with your name and email address and follow the instructions specific to the type of credit you're requesting. The evaluation link will be shared in the chat shortly, and if you're unable to access it through the chat for some reason, we will also be emailing it to all of the webinar attendees later today. All right, so we did have some questions come in through the Q&A. The first one asks, you said not to smoke weed if immunocompromised because of contaminants. Is this also true for THC vapes?
Okay, so the plant itself is, well known to have, especially the fungus in it. In the vapes, those are synthetically made, so I don't know if it would have those same type of carcinogens. I mean, same type of contaminants, not carcinogens. It does have carcinogens.
Yeah.
So I don't recommend THC vapes, not because of the aspergillus and the E. coli, but because of, 1, carcinogens. If you already have cancer, then why do you need more carcinogens in your body? And number 2, the potency. The potency in the vapes are even higher than regular marijuana, hopefully.
Yes, that's a great
And again,
point.
those are not FDA regulated. They're, so you don't really know what you're getting, like if you're getting something with a prescription.
Thank you. Another person asks, can you speak to the impact chronic marijuana use has on a person's mood?
Okay, so we have to say what's chronic. So I assume it's somebody who has a cannabis use disorder. And the biggest thing would be addiction. So your baseline while you're using marijuana would be like your usual self. That's like the graph that I told you about what happens with the dopamine. So after you're using a lot, and this is true for marijuana or opiates or methamphetamine or anything else. So when you're using all the time, then that's your dopamine baseline, then your mood or who you are. That's who you are, just to get your dopamine regulated. If you use more, then it could affect your mood differently. And I guess that depends on personality. But what I can say is for a chronic user, if they're not using, they're in withdrawal, and that will show up as anxiety, insomnia, agitation. They don't like that feeling. They are dopamine depleted. So that's something I could say that's universal. Otherwise, it's just like all of our personalities can be kind of different.
Thank you. Ellen asks, how long does marijuana-induced psychosis typically last?
So Ellen, that's a really good question. And I guess it depends on the person, their metabolism, on the potency of what they're using. So I gave you some examples, right, of the old man. He used, you know, one brownie. He was encephalopathic. He wasn't psychotic overtly, or at least that we could tell. And for him with the bad liver, that several days. When I showed you that screen of all the psychiatric patients are waiting in the emergency department, some of them are, you know, marijuana, methamphetamine combinations, alcohol. I'd rather have an alcohol person in the emergency department than a marijuana, because alcohol, the half-life and the way that it excretes from the body is reliably at a set rate. So if somebody who comes in drunk, whatever, they'll be in the emergency department for 4 hours or some average. With marijuana-induced psychosis, it'll be, you know, more than my shift. I'll be passing on that patient to the next person. And then sometimes it's days. So that, again, it depends on the person, potency, metabolism, but it is fat soluble molecule, so it goes to the brain, and it's a longer time than typically than alcohol. If everybody likes comparing alcohol to marijuana.
Let's see, Kathy brought up a point. She said that she's seeing that people are asking why there's a significant increase in mental health crisis in the US. And there are likely multiple factors, but people seem to only talk about the impact of social media. To her, it seems that cannabis may be a big contributor to that, to the mental health crisis. And do you have any thoughts on that?
Yeah, so I have the data and I haven't analyzed it yet. I need to get some more researchers, because I actually I asked the exact question. If we look at all our mental health patients that are waiting in their emergency department across the country, are they there because of cannabis or meth or their underlying mental health illness? And I also looked at time, how much time they spend in the emergency department. I wanted to, like, my theory is that if you're there for methamphetamine induced psychosis, is a little longer than marijuana or maybe other drugs. And I don't think we have the absolute answer to that. It is really sad. We're like in this first world country, very rich United States, and yet we have an unhappy population. We have a lot of anxiety and depression. Then you have to say that it's multifactorial. Does cannabis play a part in that? It has a role, definitely. I mean, I think we see that in the emergency department, but I think there's a bigger picture here of why we are you know, an anxious, depressed nature. And if you talk to young people, you know, they say that on social media. It pays out in the emergency department. Why do we have a problem? I think it's volume of medicines. There's a big study now of emergency department benchmark alliance that shows that we do have, as a nation, more psychiatric patients, and 2, we don't have places to put them. So they're sitting there, like that guy I showed you, like they're in the emergency department for 8 days. There's people in a month, they're living in our emergency department. I can't imagine that. Especially teenagers, because there's less beds, so less availability for placement and more volume.
Thank you, Dr. Love. There was another question that asked about testing for marijuana after motor vehicle accidents. Is there a test that can be used, and do you know of any proposals or laws to require this?
That's a great question, and one that Isaac, the International Academy of Science and Impact of Cannabis, really wants to take on and create the gold standard that for not just all traffic fatalities, but all violent killers, like the guy who shot President Trump, all those kind of acts are, those people are tested for THC. I think for traffic fatalities in general, those tests are done. And we have the data on that from NHTSA. Other than that, it depends on your local medical examiner or coroner whether they're going to include that or not include that. I agree that there should be a standard that's included. It's not expensive. It's part. I mean, I'm familiar with drug testing because I wrote a law to include fentanyl in all drug tests obtained in the emergency department when they're obtained. So it's, again, the qualitative measure, yes or no, for marijuana is not expensive. And there are actually states taking it out rather than they're putting more effort to take it out to try to prove that it's not a problem than just leaving it in and allowing for the data.
All right. There's another question from Nancy. It asks, can you trust a dispensary regarding how much THC it says is in a particular kind of marijuana?
So if you are a marijuana user and you want to be as safe as you can, if you went to a dispensary that's approved by your state, then you could see what kind of regulations your state has. I can only speak for California. So I would say that if you're using a state-sponsored dispensary, that's probably the safest place to go, but that's not 100%. That's not as good as going to getting a medication from with the FDA approval from your pharmacy. There are still contaminants. They're still breaking their own laws. Depends on your on the regulatory body that's overseeing the cannabis. And there's a lot of conflict of interest, sadly, of industry monitoring their own. But I do think that there's some regulation is better than no regulation.
Great point. Lou wants to know, what might you prescribe to a person detoxing from cannabis or cannabis use disorder to help with the lack of dopamine that they're experiencing during detox or early recovery?
That's a really good question. And we haven't, as a community, sadly, we should have come up with a good little cocktail. Like we had a little withdrawal cocktail for opiates that we could do before we had buprenorphine. And we don't have a good little cocktail for cannabis use disorder and withdrawing, especially for people who come in. And I challenge you, you talk to any ER doctor, and I don't know if there's any in the crowd here today. Every single day they take care of people with cannabis hyperemesis syndrome. And when they stop, we tell them, oh, just stop, but it's not easy to stop. So I would go by symptom. What are the symptoms? Is it something from anxiety? But that gets tricky because you don't want to put somebody on an anxiety medicine and add that, because now you're going to get addicted to that as you're coming off the marijuana. Or sleep, anxiety, sleep, clonidine, but there's nothing we don't have. It's something that we really need to work on. It's a good point.
Another question asks, how can we as practitioners dispel the myth that cannabis is not harmful or deadly? How can we make this information matter to the patients and clients we see?
It's really hard because you have a $1 billion industry and signs everywhere telling people the opposite. I think for many years, I saw patients for cannabis hyperemesis syndrome. I'm trying to have them understand that they need to stop using marijuana. Now, I failed at that until I got into their space and understanding, like, well, why are you using? That you'll have withdrawal, this is what it feels like, and I'm telling them something that they could look up somewhere else, right? So people want to look it up. So by giving them that type of information, like, don't believe me, go to the Isaac website, go to the FDA, go to drugs.com, go to sources that you feel are credible to get this information. So there's more and more of those resources. So I would use that, and people are more likely to try to listen to you if you come at it from a view of caring. Like, you're miserable, I believe that you're that you're hurting with this, or but you have to try, because what I see a lot of times practitioners do is just blow it off. I'll give you an example. I had a patients waiting for a psychiatric hold. We see patients with our, nurse practitioner. Nurse practitioner goes, I have a 19-year-old. He's psychotic, needs PET team. That's easy. Okay, we'll call our psychiatric team. They'll see the patient and we're done. But when I went and, checking on it, I see a 19-year-old boy pacing the room, very psychotic. And I ask him, I use marijuana, and he'll say, yeah, I use marijuana. I said, what kind do you use? And he uses the oils. It's like, okay, those oils, that's 90% THC. That's like using meth. And if I can confront this young man when he's 19 and he can understand that and understand what's happening to him, people want to understand what happened to them, it's reversible. If you're waiting for years later, it's not reversible. So I really think that we're doing a disservice. It's not easy to have these conversations, but we have to have them because for anybody who comes in drunk in the ER, I will have that conversation about alcohol, and maybe 1 out of 10 or less will hear me, but that'll change their life. And so you always have to give people benefit of the doubt, have that discussion with them and try. Maybe your conversation won't work. Maybe it'll take 10 times for them to hear it, to sink in, but you always have to try. And people are extremely thankful when you tell them that.
Those are some great tips, I think, for starting the conversation with anyone who comes into an office. All right, there was one last question that I think we'll get to. Someone was wondering that if someone who uses cannabis due to the potential for psychosis and suicide, does that then make it more likely that the care team will administer a psychiatric assessment because they may be at higher risk?
I don't think just that on its own would make you do that. You'd have to see, it's a whole picture thing. It's kind of like saying, okay, well, if you're using tobacco, you're more likely to have lung cancer. Am I going to get a chest X-ray on everybody who smokes? Probably like not. You'd have to have some symptom. You have to be coughing, and then I'd get the chest X-ray or something. And I think the same thing here. If you're doing an assessment, somebody using marijuana, if they don't have any symptoms, then again, I would want them to know. I'd probably put a little thing. It's like, hey, you should know your brain is still growing. You want to, think about that and understand the risks, or say something like that, but not automatic, psychiatric assessment for anybody who's using.
All right, I think we are going to stop the questions there. Unfortunately, we didn't have time to get to everyone's, but we want to make sure we have time to wrap up everything and give you information about your the continuing education credits. So thank you again, Dr. Lev, for joining us today and sharing all this wonderful information and real life cases that you're seeing in your work.
Hey, thanks, everybody. Thank you for all your work.
All right, we would greatly appreciate your feedback so that we can continue to improve our future webinar offerings. Please use the link in the chat to complete our feedback survey. And as a reminder, this live webinar has been approved for 1 social work continuing education clock hour, 1 specific McBAP credit hour, and 1 credit hour of CME. If you're requesting any of these continuing education credits, please fill out the evaluation form with your name and email address. If you are unable to access the feedback survey through the chat, the survey link will also be emailed to all webinar attendees later today. For the next presentation in our series, Dr. Kelly Young-Wolf will be presenting Cannabis Use During Pregnancy, Research from Policy to Practice. This will be tomorrow at noon, and Dr. Young-Wolf's live webinar presentation will also be approved for 1 social work credit, 1 specific McBAP credit, and 1 credit hour of CME. If you have not yet registered for other webinars in this series, you can do so using the link in the chat or visiting washtenaw.org/marijuana. We hope to see you at the next webinar, and thank you so much for your participation today.